All right, excellent. Welcome, guys. Thank you for joining us for another round of Probing the Literature. It is Bowel Month, and there is a lot to talk about. So we have two great articles to discuss. And as usual, we are going to start with the author segment where we've invited an author, and then I think a couple more might be trickling in over the next 20 minutes. They've got some interviews and things like that that they are going to hop out of to talk about our first paper, and then we'll do a small group session breakout for the second half of the session, talking about gastric ultrasound for assessing aspiration risk. So without further ado, let's get started with the first segment. So we are going to be talking about POCUS for looking for complicated diverticulitis. So I'm not sure if you guys have really started scanning for this much in your EDs, but at our shop, we've been, for the last couple of years, kind of more and more interested about looking at if we can avoid CT scan by starting to scan for diverticulitis. And so it's been kind of a personal interest of our group. And so the team over at MGH had a recent paper come out in 2022, kind of assessing their protocol and seeing its outcomes for able to detect diverticulitis. And so Andrew Goldsmith is one of the authors on that, and I will have him talk a little bit about his experience with the study and the findings and kind of implications for future use. So Andrew, take it away.
Oh, thank you, Nicole, and thanks for having me. For those that don't know me, my name is Andrew Goldsmith. I lead the division of ultrasound over at Brigham and Women's in Boston. This study was actually done when I was a fellow. Hamid would probably be the lead author, is the lead author on this one, and totally his idea. But Nicole, and steer me in the right direction if I'm going off topic, but you just want me to go over the general article and tell you about the results?
Yeah, tell us about your experience doing the study, kind of pearls and pitfalls, what the motivation was. Just walk us through it.
And so this study was a prospective observational study of patients just coming to the ED. And the main gist of this and objective was to kind of look at the test characteristics of this TICS protocol for patients suspected of having diverticulitis. The main two objectives was, one, see if it is as good as CT, and two, can you identify an ultrasound whether it's a simple diverticulitis or complicated diverticulitis? And the reason behind that is if you take a step back, when you think about it, you could basically say that somebody clinically has diverticulitis, why not just give them antibiotics and then proceed on, discharge them, who cares about the CT scan? However, it's that patient population that may be complicated and actually need intervention is the concern of sending that patient population home. And the goal is, can ultrasound actually entirely avoid that CT scan? And so that's what this study really mainly objectively tried to find. And so this TICS protocol, TICS, and the acronym is for T is for thickness of the colonic wall, I is for intramural air, C is for colonic Murphy. So basically, is there tenderness when you push on the left lower quadrant? And S for straining of the pericolic fat. There is a figure in the article in figure 1 that shows a good example of this for anyone that's never looked at this. So basically, the protocol is you look at for the anterior iliac spine to the lateral wall of the bladder in the left lower quadrant. And the thing I would kind of emphasize here is go where the patient hurts. And so just like appendicitis, if they put one finger down where it hurts the most, it's very similar, and tell them to put one finger down where it hurts, put the probe over there, sagittal transverse, and hopefully you can see what you can see in figure 1. Thickness is greater than 4 millimeters. You're looking for that intramural air, which is the top of that figure. And this kind of hyperechoic white fatty tissue is that straining that we look for. That if you haven't been familiar with it, look at your next appendicitis, and you'll see that hyperechoic area as well there. All these patients got a CT scan as well. And so we compared the results of having a positive TICS with a positive CT scan. We also looked at the percentage of patients that had simple and the percentage that actually had complicated diverticulitis. And so in figure 2, you can kind of go through enrollment and see how many patients ended up having diverticulitis, how many were simple, how many were complicated. Yes, and so the results at the end of the day showed that the test characteristics are quite good, not perfect, but better for just all diverticulitis in general for sensitivity purposes, with a positive likelihood ratio in the 13s for complicated. The key here is that you weren't really able to rule out complicated with ultrasound. Our sensitivity was only 54%. But if you did see it, you did see free fluid around the bowel with signal potential perforation or abscess. You were highly specific at 96% to say it's complicated. Now, when thinking about that, you take a step back and wonder, should we be doing this in general? And I'd love to hear your guys' thoughts. To me, when I see a high specificity of complicated, I'm going to have to get a CT scan anyways for that patient population. And so mainly to convince my surgeon or IR to go after drainage or figure out how big of an abscess it is or whatever it may be. The question is, for patients with other clinical variables, such as their abdominal exam is relatively benign, which we did not account for in this study, is it okay to say that they have simple diverticulitis and potentially just give antibiotics if you do see it? That's kind of where the next component of this would be. So if you think about this, we basically said that test characteristics are okay, better for complicated than for simple, but the sensitivity is much better for the all simple. So if that's the case, how do you differentiate between simple diverticulitis and complicated diverticulitis? Well, the answer might be in more of the clinical variables, and that's how I foresee the next study happening, is kind of coming up with a scoring system or statistically model to show that this patient population or this cohort is safe to send home, which would actually increase the utility of this modality for us. Yeah, that's kind of where I see this study going. Any questions? I kind of went through this relatively quickly.
Yeah, thanks, Andrew. And when you say safe to send home, do you mean safe to use POCUS only for diagnosis as opposed to using a CT as well? So saving opportunities for CT, or what do you mean by that?
Yeah, so what I mean by that is decreasing CT utilization for simple diverticulitis. So I think we can all agree that our dread is to send home a complicated diverticulitis or send somebody home with an alternative diagnosis that we just missed, right? And I do a lot of stuff like this on bowel obstructions, but like that's that dreaded miss, right? Now the hit here is, how do you make your sensitivity almost approach 100% for simple diverticulitis or specificity as well? And so if you see it, great, I'm going to give antibiotics. Or if you don't see it for all cases, are you okay sending all of them home with nothing? And so that is the dream. And obviously just the ultrasound by itself is not good enough. And so the question next is, how do we add to those? How do we add to it?
That makes sense. Larry, did you have your hand up?
Yeah, great study. Thank you so much. I had a couple of things. First, with appendicitis, the whole ALARA approach to reducing radiation, we didn't approach it from the standpoint of replacing CT. That is an aspirational goal I think we all share. But the immediate goal is, what is the impact of sono first in avoiding at least some CAT scans? And I was wondering if you had data on avoided CTs, or whether the clinicians were not allowed to make that decision. My second question had to do with the fact that diverticulitis, diverticulosis is very common. Some people argue it's not even a disease in the United States, since the prevalence is greater than 50%, but it's definitely a different disease in younger individuals than older ones. So I was wondering if you looked at the data, I'm not even sure where the cutoff would be, let's say 45 years, and see if there was a difference in the test characteristics in younger patients versus older patients. When younger folks get diverticulitis, they're more often going to the OR because they seemingly have a more serious disease. And then the last question had to do with stranding. At least with appendicitis, again, periappendiceal fat stranding is important both from an ultrasound and a CAT scan standpoint. I was wondering if there were any low BMI patients who had little or no fat to strand, and whether that impacted the test characteristics.
Okay, so let's take it from first question is trying to not avoid CT scan for all. And I think that is the case in this one. And so when I think about appendicitis, I do think about doing an ultrasound first approach. And the nice thing there is if you have it, you have it. And you are trying to avoid CT scans in specific populations, but you're using all of your clinical data to try and make a best case assumption that there's no other complicated features. And there's no study with appendicitis, whether that's free fluid, that I can think of to kind of clue you in that it's more complicated than not. But I think that's where this is going, right? As we start thinking about ultrasound in general, where we as a community are very good at looking at certain modalities and saying that we are good at doing this and that here are the test characteristics. The next step that we need to start conquering is how do we integrate this into our clinical workflows? And I think for the SAEM appendicitis and diverticulitis, it's identifying that cohort that are safe, that if you have positive or negative findings, that you're safe not doing any further testing. And that's just going to take a lot more data and a lot more big studies. As for
Andrew,
this,
you've started looking at that for things, other intra-abdominal pathologies like SBO and kidney stones too, right? So that's kind of a common theme that you're starting to move towards. That's
correct. I think that's where our literature needs to start moving to. In fact, we just did a SBO study looking at need for urgent operations in the first 24 hours, and we can pare that down. And then how do we find that cohort that if you have a positive SBO and ultrasound, how do you find the cohort that's not going to the OR, can get conservative management? Same thing applies for this type of stuff, and is basically using a statistical modeling to try and figure out that cohort. Second question had to do with diverticulosis and diverticulitis. I'll be honest with you, I don't know if there's any difference between age groups when it comes to diverticulosis versus diverticulitis and severity of disease. But I think that goes exactly to the point what I was trying to make before, is that if there is an age component to this, if you integrate all of this clinical data, all of the metrics associated with each patient, you can make a patient-specific decision. And it might be the case that early diverticulosis leads to diverticulitis more severe. I actually don't know the answer to that. And then the third question was appendiceal fat. That's a good concern for low BMI patients. That being said, there should be enough other ultrasound metric factors there to clue you into the positive diagnosis. But we did not do any modeling. But I know Hamid has come up with a new model based on how many positive pieces of this and how it changes the test characteristics. And he either just published that or it's in publication somewhere, but I can't remember where. Did I get all three questions? Sorry, I was trying to remember all three by the end.
Yeah, that was great. Thank you so much. That was awesome.
Thanks. Any other questions from the audience? Otherwise, I'm curious about something that Andrew mentioned earlier. Any other questions from everybody else?
I was just wondering, are you or any of the other authors using this in your practice? And how was your training that I was just wondering how, because I assume it seemed like you were all ultrasound people who did the studies.
So, and this is something Hamid and I have talked about at length with this modality. It is, he is probably the sole person that is doing this for all patients with suspected diverticulitis. It is not as easy of a mode study that I find to do in my regular practice. The question is, would I do it as I suspected simple diverticulitis and then did a POCUS and it's obviously there? I try at least, but that means they don't have rebound tenderness. They don't look ill. I'm like clinically pretty confident going into it that they have diverticulitis. But that's the be all end all question, right? Is can we put this into our workflows? And so if it's a hard and it's operator dependent, the next layer to this is, can we automate it in some way too? And I don't know the answer, but these are all questions for future studies potentially.
Andrew, I have a question. My name is Kevin Pyro. I'm an internist out of Oregon Health Science University. I run our POCUS
Kevin,
program
nice
out
to meet
here.
You.
The thing I keep wondering is about the complicated cases, right? Because that's the concerning number to me as I look through this study is like, if I'm possibly missing all those ones, that's the area where this is really going to lead me astray, or I might be falsely reassured. So I was wondering if like if kind of looking at this study, what the discussion was, were there other findings that might have clued you in that a case was complicated? I don't know if those were negatives because they had perforated and there was free air and there was like alternative findings we should have been able to say, hey, this was complicated, or if it was just that it made the bowel more difficult to identify because there was an abscess. So I was kind of curious about whether there was any observations made based on what y'all reviewed on the complicated cases.
So I agree with you, Kevin. Nice to meet you first. Second, is that I agree with you. That is the dreaded like concern, right? That you send somebody home with a complicated and they come back and they need an intervention. From a review of the false like negative cases that we had, like there wasn't any like specific like reason why we missed, except for the image quality not being great, or like there was air and there was other things like confounding that, whether it was big BMI or whatever it may be, that clinician who was doing this, because don't forget that the clinician made the decision of declaring if it was diverticulitis based on the ultrasound findings up front or not. They made that decision. So, and this goes back to operator dependence, is like anything with point of care ultrasound, the clinician at the end of the day is both interpreting and integrating that care, and they just made a wrong call. Even though on these images, you can't see fluid, you can't see abscess, you can't see anything that was obviously like, this is what it is. What I will say is that none of these ended up being like needing intervention eventually that was missed. And I wonder if you look back at the New England Journal article of kidney stones and the ones that were missed there, none of them actually like killed anybody or led to anything serious. And so like, I wonder if at the end of the day, for something like this, does it actually matter in terms of morbidity, mortality? But that requires a lot bigger N and a lot more sites, but like, it's something to think about, just like the kidney stone paper.
Yeah, I keep wondering if there was other signs that, like, as you kind of mentioned, if there was like a symptom driven kind of approach or some sort of score that, hey, we can risk stratify this person has unstable vitals, they're looking sicker in some way, that could kind of say, hey, we need to get off the POCUS first kind of approach and just go straight to CT. I've been starting to scan these in my practice, and I see much more like Crohn's disease and IBD flares, but the positive cases do seem to be pretty obvious when someone's actually got disease.
Yeah, my thought process, and I honestly, it's been such a long time now, is I can't remember if there was exam findings or vital signs findings, but like, if I could change the study, I would have collected everything at the time to be able to do that analysis now, because I think that's where we as a community need to go with these types of modalities.
Yeah, 100%.
The good cautionary tale for fellow research: collect everything now. This is Andrew Shannon. I want to chime in with a persnickety question about when you're looking for these complicated diverticulitis, we'll pretend that's a word, and you're looking for that free air. Was there anything about maybe trying to put them in left lateral decubitus and look over the liver or something to sort of really try to make the free air pop? Or was it really just kind of you're still focal in the left lower quadrant when you're doing it?
Focal left lower quadrant, TICS protocol. Complicated was more aimed at seeing free fluid than necessarily free air, but it was definitely looked for free fluid, suggesting a perforation or abscess had occurred.
Great.
Great
All
question,
I just have
guys.
one more comment. I'm sorry, Nicole, and thank you so much, Andrew, for being here. And I forgot to introduce myself. I'm sorry. I'm distracted with my dogs, but I'm Lynn Rapolo from John Peter Smith Hospital.
What type of dogs? Even more important question.
Oh my God, I got a big golden doodle and a little Yorkie poo who's making the most noise. But anyway, so I was just like, I really like your study and I really appreciate you being here. But I was trying to think, how could I use this to change my practice? And the patients that always come in, and we know those patients that say, I have a history of diverticulitis. This is just like my diverticulitis. And we really don't want to scan them again because we've looked at the chart and they've been scanned a number of times. That, because the specificity was so high in your study, maybe this might be a case for those patients who come in again and you're like, oh, this is they say this feels like my diverticulitis. I don't know. I just was wondering your thoughts on
So
that
I
particular
would
patient
argue
population?
that is how I foresee it right now. But here's the question I would shoot back at you. If that same patient came in with left lower quadrant pain, stable vitals, and normal abdominal exam and said they have diverticulitis, I bet you there are PCPs out there that will just treat this without an ultrasound, without a CT scan, and see if they get better. And the same goes to kidney stones, right? When you look at that kidney stone study, which I think is one of the best ultrasound studies we've done in a long time, is if they say it's a kidney stone, they've had a kidney stone and they're stable, why do we even care? It's a kidney stone, right? And so I don't know how ultrasound actually like adds value without more precision on what we're looking for. And I advocate for any of the fellows here who want to do these types of projects. These take years to actually come by, but like we need to do better research when it comes to finding these cohorts where we can actually create these clinical workflows. And that's where I think we are with a lot of these modalities is we got to find those right cohorts to identify which ones can go home safely and avoid CT scans, because that would change management.
Sure. I mean, I don't scan them all, and sometimes I do share decision making, but sometimes they get progressive, and if they're recurrent, and sometimes they need some intervention. But anyway, I was just it's just a thought. So I thought.
No, I totally agree with you.
I look at it as a data point. You know what I mean? You got another data point that says you can send this person home, and I could easily do this at the bedside. So you know what I mean? It's just a data point that it might be meaningful. So
yeah, I think we all are guilty of the therapeutic ultrasound where the patient's like, well, I want a CAT scan. We're like, well, you do the quick POCUS, you show them the thing, and they're like, okay, now I'm okay going home. I think we're all pretty guilty of that. In fact, doing a study on that would be, I think,
but Daniel,
fantastic.
that's a very real phenomenon. I was trying to develop a protocol and look at the value of reassurance. We all send home 75% of the people that we see, and I was purposely trying to avoid including ultrasound in the protocol because I'm kind of typecasted that way. And I couldn't leave ultrasound out, because the literature on reassuring patients in the ET is filled with the effect of ultrasound to reassure patients. A quick question from Kevin, Andrew. The indeterminate ultrasounds were excluded. How many were there? Why were they excluded? And they really should be in at least part of the data analysis.
If you go to figure 2.7, we're excluded for indeterminate results. And I'm trying to remember, because it's been so long, why they were excluded, to tell you the truth. I can get back to you on that question though.
I think, given the dynamics of the study, it's kind of like a prospective description of the characteristics of a new diagnostic modality. And I think in that situation, it makes sense to exclude the indeterminates to try and get a clean understanding of what does this thing usually do. Now, in like those future studies that you mentioned with high numbers, you could do your intention to treat intention to treat and why am I blanking on it?
Number needed to treat, or
no, your per protocol analysis of what you would do in a real life situation. So I think those can happen in those later studies. I think for the people who are on the call, this is a great example of when you're first describing the capabilities of a new diagnostic modality, you really want to just have nice, clean descriptions. And yes, you could do a per protocol later on. You could have it as like an appendix, you could, whatever. But this, I think, as it stands, to me, I understand why it looks this way, and I like it. So I think if people have questions about per protocol analysis and intention to treat, just Google it.
I actually think, Dan, that's exactly why, if I remember right, is why we did it. We were doing this study before the anal study came out, and we were almost done with our data collection. And like, I don't know if we would have, if the anal study was out beforehand, I don't know if we would have changed our thought process behind it. But that's exactly why, if I remember right.
Yeah, I think that's all well and good, but your abstract in a case like this should state, the good news. We were able to obtain usable images in X% of patients.
That's fair.
And if that number is 45%, you got an immediate problem. But For you guys, it was whatever it was, 85%. That's great news. So you should be reporting it.
That's fair.
For the non-stats kids out there like myself, I think of it as, does it work? You can exclude those, and then will it work? You must include them when you're sort of trying to think about a new diagnosis or treatment.
Absolutely, guys. All right. Any final burning thoughts? We're right at the half hour. No.
Just tell
All right.
Hamid we said hello and awesome work.
He's traveling right now. He's very sad that he couldn't be here to join us, but he's on a much needed vacation, so he'll be back in a week, I think, if that's right. But he sends everyone love for sure. All right, thank you so much, Andrew. That was wonderful. That's really great. I love trying to scan these. I don't know that I'm great at it yet, but it's a great modality to get started with. So with that, we are going to start to move towards our second article, which is on using POCUS for assessing gastric volume status to assess aspiration risk. And so I know Dan is working on putting together small groups. You all ready? Okay. So whenever you're ready, Dan, we can move towards the small groups.